I think we'll stop here, and if you can please go ahead, Dr. Gurgis, and discuss the IDH data.
Sure. So I'll present the IDH data that was presented in 2017, ASH 2017, enasidenib in refractory relapse AML, a phase 1/2 design. And there's there are two phases into this: the phase 1, the expansion phase, then and the phase 1 escalation phase, then the expansion dosing. So it was designed for patients with advanced myeloid malignancies with IDH2 mutation. The IDH2 inhibitor was given continuous for 28 days cycles. The cumulative daily dose was a huge range, 50 to 650 milligram. And in the expansion phase, relapsed refractory AML above 60 or younger than 60. And there was a proportion of patients with upfront AML, untreated AML. And I think there were about 30 patients, more or less, and some ineligible, other patients that were ineligible for other arms. The expansion dosing had enasidenib at 100 milligram PO once a day, and that's for the AML group, and that had about 109 patients. Just like phase 1, early phase 2 studies, the key endpoints were the safety and the maximum tolerated dose. The efficacy of enasidenib in mutated IDH2 relapsed refractory AML. So the highlighted two boxes, I'll go into the second box, the complete remission, 42 patients out of 214. So that's approximately 20 patients. And for all patients, was about 20% for the AML group and 19% for all patients. CR and CRI were 38.8% for the AML group. Then the overall survival by the best response, those, of course, who had CR had the best overall survival, approximately 20 months, 19.7 months. The non-responders had 7 months, which is not so bad, actually, for relapsed refractory AML patients. It's much less than that in the real world. And the non-CR responses, that's the CRI and others, had something in between, 13.8 months.
All right, well, thank you very much. And I think, again, this kind of brings up the point that, as a single agent, because I think we have to have the perspective, as you kind of mentioned, that even with chemo, like what we were doing 7, 8 years ago, FLAG-IDA, MEC, CCUC, LAG-M in this population, 30%, Gail Robos had a big multi-arm study, LSI-tarabine, and if you look at it, everybody was hitting 20, 30%. So to get above 35, 40% and to get that survival is with a single oral agent, which is really, really quite safe once you just know about the differentiation, is very good. The other thing I think is this kind of changed, actually it was Blina that started it, but this changed the paradigm for AML with responses about CRH, becoming meaningful. And I think this is something that almost all the physicians agree with, probably patients, and it was really good that even the FDA felt that this was meaningful, because we always had this very high bar of platelets of 100, ANC of 1, whereas if I saw somebody in clinic with platelets of 60 or 70 and ANC of 0.8 and staying that way for 2 months, I was very happy. So I think that the CRH, especially in the setting of these non-induction cytotoxic therapies, is a very meaningful benefit. We're seeing it used with aza-ven, with gilteritinib, and in fact, a lot of these patients actually are doing quite well. So with these new agents, there's a lot of discussion about response criteria that for 20 years we were on the train of only remission, and not only remission, really only remission MRD negative mattered. And now we're actually almost, with the new agents, taking a step back, because with IDH, with FLT3, we're seeing that the MRD negativity may not correlate directly with survival. They showed that in the IDH paper. So I think there's going to be a new learning curve with these new agents that is going to be different from cytotoxic. So very, very exciting and interesting data. And with that, we'll move to the next case. Thank you very much.